Okay, so we've shifted a little bit very much from the discussion on Friday, where we were looking at micro-level interactions, we were looking deeply at the software of systems, to much more of a macro perspective on how people at the top of a system are thinking, and ways of researching at a macro level around financing. Now, obviously, it's a huge field. You've done lectures on it. There are a lot of different dimensions of this. And as you've done, I believe, quite a few lectures on health systems financing, I'm not going to go over the theory of that, really, except to touch on it quite lightly. But what I want to talk about now are these two very distinct methodologies that represent quite different traditions, if you like, all within the broad family of health policy and systems research. And one of the tensions and challenges of being in the field is, the economists feel we focus too much on the soft stuff. The social scientists feel the economists don't really understand how a system works. And the field has to be able to accommodate those tensions and debates. And these two studies represent that set of tensions and different perspectives, if you like. So again, we're talking pretty much at the macro level here. And I think we all agree on that. The current paper is, we're interested in this building block, okay? But it's an impact study, so it's interested in the relationship with social and financial risk protection. So that's how we situate it, if you like, in the field of health policy and systems research, which, you can point to a building block and a set of outcomes. The stakeholder analysis is perhaps working more at that kind of interface, okay? More at the interface between governance and financing decisions. And in fact, the stakeholder analysis, you could have said, okay, if you wanted a qualitative methodology, one qualitative methodology would be to say, out of the policy, the RSBY policy has not worked, okay? Let's identify all the stakeholders involved, positions, power, and between that national policy and the point of service use and the point at which people pay out of their pockets for services are a massive intermediaries, okay? Huge pathways, complex pathways. So you could put all of those pathways out there, and you could look at all the key players around service delivery. You could look at the insurers, you could look at the private hospitals, you could look at the demand side, you could look at the users, you could map all of the stakeholders, their interest, power, and positions on this, okay? And you could then try and begin to answer the question why. That might be one way to approach it. Or, when this policy was first defined, okay, if there was interest in an evidence-based approach to it, although I think what our previous discussion suggests there were overwhelming macroeconomic drivers of this rather than evidence-based policy making within the health sector, perhaps. But if the policymakers, the people who designed RSBY, got together, as they might have done informally, and mapped all the key players, okay, and said, look, these are all the people who are going to influence, oppose, are able to shape the implementation of this policy. What are their positions, and how do we preempt some of that and look at it in terms of our design? So you could have done a stakeholder analysis at the beginning to help you think about processes of implementation, or retrospectively to try and answer the why question. Perhaps not necessarily the most relevant qualitative methodology, but we could talk about that. All right, so have you you've got the Kutzen framework. Have you seen the Kutzen framework? No. All right, so you saw in that stakeholder analysis paper, there were three terms there: revenue collection, pooling, and purchasing. And they analyzed policy according to those dimensions. So this is basic, one of the sort of WHO-based frameworks, if you like, that unpacks that financing block. And it says if you think about financing, you can divide it into revenue collection, so how the money gets into the system, typically through payment of taxes, through payment into an insurance scheme, or your own personal savings account and out-of-pocket payments. Okay, so that's how money gets into the system. You can look at whether that money is in pools or not. So if it's taxation, it's all in one pool. If it's insurance, it will be lots of different pools. Each insurer might represent a pool. And if it's out-of-pocket payment, it's in thousands, millions, billions, actually in India, of they're individual pools, they're not collective pools. So that's one thing you're interested, how much, the money that goes into the system, how much are we able to consolidate all of that, actually, and purchase then services in a rational way. And then how does the purchasing happen? Who gets paid, public, private, out-of-pocket, prospective payments, budgets, okay, so that would be the purchasing function. So you could analyze financing mechanisms across each of those elements, and it's a way of unpacking, if you like, something like RSBY or National Health Insurance in South Africa. So the Coutson paper, the Karan paper is interested primarily in this relationship, okay? A particular purchasing mechanism to buy inpatient hospital care, all right, an state insurance mechanism. So they're interested in that purchasing mechanism. Does it lead to that? But what this framework shows is, so all of these are just modified versions of the WHO building blocks, reconfigured around those core functions. And in fact, if you read the WHO 2000 report, these are the terms that, so it was the original WHO framework. But it's actually the building blocks around that. So resource generation is a combination of HR and drugs and supplies and information. They've plugged all in there. There's your service delivery, and stewardship is the governance and leadership one. And these are your intermediate elements, and these are your goals. So that obviously your financing system would deeply influence your nature of your service delivery and through quality, efficiency. So all of these things would be influenced quite heavily by your financing option, and then those would in turn influence your outcomes. So this is starting to represent a little bit the complexity of the pathways that Karan was just trying to look at there and there without trying to get really at the why, a little bit of the why in between. But some of the why would look, and this is to some extent hardware, but could also be software why. And then the Gilson et al. Paper is really looking at these kinds of interactions, or it's trying to look holistically at this interface. It's not really looking at impacts. It's not an impact evaluation. It's just trying to understand how these things happen through the lens of political science. Okay, so that's why insurance. That's why we have universal coverage. Okay, is this scenario of financing across the globe. So if you look at, these are all the elements, these are all the sources of funding, okay, revenue in health sectors. In high-income countries, you'd have a combination of social security, taxes, out of pocket, other private, prepaid. So you'd have a mix of modalities. But that dark blue, the out of pocket, would be a tiny percentage of total expenditure. And this is a low and middle income. Sorry, this is out of pocket. Apologies, that's other private. This is out of pocket. And as you get to poorer countries, actually what you find is that this blue bar, the out of pocket expenditure, gets bigger and bigger. Okay, And as this seems to be the scenario in India, 70% out of pocket, okay? Which is, and that kind of scenario is a profound source of impoverishment. That's when health care becomes mechanisms through which households lose their social status and economic status. The greater your out-of-pocket payments, the greater the risk of impoverishments through healthcare. So UHC, universal health coverage, in its fuller definition, its full definition, is really about allowing people to go to sleep at night, thinking that if they get sick tomorrow, they don't have to draw on their savings, sell their assets, borrow money in order to get health care. And the biggest fear of households who rely on out-of-pocket payments is if there's a major catastrophic event, health event, an accident, a head injury, major surgery, whatever, that causes impoverishment. And the goals of UHC then, and that's why we have everybody doing research on this. That's why we have Winnie Yip, who's one of the top people globally in this field, supervising PhD students, and that's why people are interested in RSBY and what it's doing for out-of-pocket payments. And what we're saying is that this financing mechanism hasn't changed that. That's the conclusion of their paper. All right, so that's the end of the primer on financing, that's all. All right, so then let's come back to the methodological questions. Okay, so as I said, this article beautifully has impact evaluation, very helpfully in the title. So it allows us to look at that body of work. So simply put, what is the impact of a program on an outcome of interest? So, you know, impact evaluation can be on small things like the role of a particular, well, that wouldn't be small, but let's say a conditional cash transfer on uptake of deliveries in a maternity. It could be something very specific. It could be the impact of a school health promotion program on sexual behavior of youth or other health promoting behavior. So it can be used in a variety of ways. It doesn't have to be just used in health systems or financing. And these methodologies might be applied across the board in the field of program evaluation. So the key feature of it is causality. So it's not descriptive work. It's not just trying to say, this is the financing. It's trying to say, does A lead to B? So it's grappling with causality and attribution. And that immediately brings in a whole lot of methodological considerations that an epidemiology course would teach you very well, okay, is how to think about causality. So many of those common concerns would apply here. It can be prospective or retrospective, okay? So the Karan paper, is it prospective or retrospective? It's retrospective, it's looking, going back. And the other one was more prospective. It's interested in effectiveness rather than efficiency. So it's rather than efficacy, sorry. So it's not saying if in a district we, under experimental control, we allocated households to insurance and others not to insurance, or we allocated some districts to insurance and not to others, what would happen? Follow them up over time under the investigator's control in a well-designed approach where you follow quite carefully implementation. This is grappling with what's happening in real-life systems. Okay, when you introduce these ideas, and particularly at scale. So that's what Karan are trying to do, is trying to say, look, if you're trying to influence a whole country, what happens to the effectiveness of something? It may work at a local level under experimental and investigator control conditions, but when it's in the routine system at scale, what happens? And that's the notion of effectiveness. And very often it uses existing sources of data and combine sources of data. So that's what Karan's done. They've used available sources. They couldn't survey the whole of India. So they've used program data, RSBY data at district level, and analyze the NSSO data. And in that sense, they're both secondary analysis. And when you were talking about primary and secondary, I think you meant the primary objectives and secondary objectives. But all of this as a methodology, secondary data analysis. Okay. So the key challenge, and this comes from a methodology reader which I've put in your Dropbox, by the way, it's the Health Policy and Systems Research Methodology Reader, in which there is a section on impact evaluation. So if you want to read more about it, it's there. And this is what Kara Hansen, who was the author of that section, said. Although there is a rich body of literature on health program evaluation, the work that focuses on system-level interventions is smaller. So in programs at scale, it's not classic experimental conditions. Randomization is not possible into intervention and control groups. And in fact, where you do have control groups, as they had, they may in fact be systematically different. So there may be a selection bias. We don't know that the districts that took up RSBY weren't the early adopters, and different in a whole lot of other ways. Okay. And in fact, you may have no control group, so an intervention that is implemented across the whole country simultaneously. You may have no control groups whatsoever. So you don't have what's called the counterfactual. Okay, remember I introduced the word rival explanations in case study. This is another word, no counterfactuals. So what would happen if you hadn't had that intervention? Would it have would you have seen the changes or no change? Okay. The other problem is that it's implemented in context-specific ways, and we know from Stephanie Topp's article that a facility is a context, actually. Each facility has a culture, never mind a district, a state. So how do you get your head around that? And also it's implemented in complex systems. So the pathway between an insurance mechanism and right to the end at the point of use is circuitous. It's not a straight line pathway. It goes through many, many processes, intermediaries, feedback loops. And in fact, you could do quite a nice causal loop diagram around the implementation of RSBY. Okay, around feedback, positive and negative loops, working through those different elements, for example, in the Kutzen framework. So quasi-experimental designs are really the standard in large-scale impact evaluation. And those would be either before or after. Okay, so you look at the situation, one NSSO survey and the next NSSO survey. You might do before, after with a control group, which is what they did, okay? And then this methodology might be deployed, the difference in differences, and I'll explain that. You may have something called a step wedge design, where if you're rolling out something over time, you can look at all of your districts, and the districts that haven't been enrolled yet can be service controls for those where it has been enrolled, and as you enroll, then they become intervention districts, and they've got their own historical controls. So you can work with a step wedge design as well. More complex because you have to work with lots of moments in time to capture all of that. And then there's this analysis process called propensity score matching, it's a design element, propensity score matching, and I'll explain both of those now. So what does difference in differences mean? It means that if you've got District A, okay, which is the intervention district, and let's say this is trends in out-of-pocket payments. Sorry, let's assume this is the intervention group, okay? District C, out-of-pocket payments, there's a trend happening over time, and then ignore that comparison group, let's call it the intervention group, and then you introduce RSBY here, And this is what happens to the out-of-pocket payments. They go from 0.78 to 0.81. Okay? So let's say that's the intervention group. These are your controls, and they start a little bit lower because, remember, we don't have randomization, okay? So we can't control for baseline differences. So they may have a different baseline, and they're going along this trajectory. RSBY comes here, and the out-of-pocket payments actually go higher. There's a steeper increase here, okay, than in District C. Okay, so what a difference in differences simply says, instead of comparing the average, instead of comparing that, okay, and comparing that and comparing that, we recognize that these have different starting points. So what we're going to do is subtract that from that. Okay, so 0.78 from 0.81 is 3. Okay, and we're going to subtract that from that. So that's 14, that difference. Okay, so that's your differences. Those are your two differences. So it's simply saying what is the level of change that's happening here. And then what is the difference between these two differences? So it's what? What is the differences? 14 subtract 3, which is? Yeah, so 0.14. Yeah. So the difference, so this, you subtract that from that, which gives you 0.03. Yeah. And you subtract that from that, which gives you 0.14, and you subtract 0.34, gives you 0.11. That's difference in differences. Easy peasy, hey? Nothing magical about it. All right? And the reason, and I've put in your box, a text in your Dropbox, a textbook on impact evaluation that's got a whole chapter on difference in differences. But you'll see it very commonly in these methodologies. If you are someone who's oriented towards this kind of analysis, you will see that word coming up, difference in differences. And actually, it's a way of dealing with differences in baseline. And what you assume is that this road being taken here would be the same if you had the intervention or not. It makes that assumption. Which may not be correct, but it's saying, okay, well, let's assume. So then your difference in differences is 0.11, and that's what they did. They subtracted the changes in the intervention districts from those in the control districts. That's all they did. Yeah, Malu?
So, ma'am, in order to make some kind of a meaningful conclusion out of this, we will also have to consider the context when we have to make a conclusion as to it is because of this intervention that probably this difference happened. So then do we know that statistically? Do we control?
Okay. Yeah, brilliant. So that's the next question. And that's propensity score matching. Okay. So what that does is, so it tries to say, we understand that there may be differences between in districts that that have taken up the insurance. They may have a set of other factors, socio-economic, political, health worker related, leadership, whatever you like. Okay, so those would normally be called confounders. Yeah. So what propensity score matching does is it's really trying to control for, it's a form of matching, like in case control studies, is you find other districts that match your district, control districts that match the intervention districts. And propensity scores, so you might have, different levels of economic development, different politics, different gender profile. You may have a set of factors which it's hard to control for individually, because then you'll never find your matching district. So you put all of that into a score. You create a score, okay? And then You create a score for your intervention districts. It's like a form of factor analysis, principal component analysis. It's similar kinds of ideas. You create scores, and then you find another district with a similar score. Okay, so that's all what propensity score matching is. So, I mean, a lot of statistics is, you know, if you just unpack it, it demystifies it, all right? So, and methodology. So difference in difference often goes with propensity score matching. You'll often find those two concepts aligned with each other. All right, any other questions or comments? All right, so that's how they would work with questions of rigour in a quasi-experimental design around impact evaluation. But there are other steps you could take to try and answer that question. What is the impact of RSB1 on out-of-pocket payments? And is to try and grapple with the high and wide questions. Okay. And increasingly in this field, people would say you need to combine designs, you need multidisciplinary teams to do this kind of work if you really seriously want to know, as a policymaker, what is really going down. So that would be one approach. The other is to draw on what's called theory-based evaluation. Okay, and remember in case studies, we said, if you're going for a single case study, you need to think about theory around your constructs, particularly if you're looking at complex phenomena. And so this is an enormous field in itself, theory-based evaluation, and the realist methods fall within this broader terrain. So you draw on theories surrounding the phenomenon. So what is the theory around the pathways through which a hospital-based insurance mechanism may impact on out-of-pocket payments? And you can draw on what others have written about it. You can also develop a program theory, or what's called a theory of change. And you know, how do you understand the influence of different factors and how they work? You could do causal loop diagrams around that, a theory of change. Or you could draw up a more linear logic model or results chain, which would look something like this. You've all seen this kind of logic model. Okay, you look at the inputs, financing, the activities, service delivery, outputs, coverage, and then come to the outcomes. So you could map the whole results chain and look at unpacking, if you like, the supply side when you're looking at really interested in what's happening in the demand side. Okay. So that would be one process you could undertake in impact evaluation, is really try and spell that as you're designing it. Another way is to look at some of the constructs that people are developing in the field of implementation science. Okay, that actually you develop an intervention or a policy, and it has to go through a series of steps before you can even begin to think about coverage and then outcomes and impact. So you could look at questions of acceptability, you can look at questions of adoption, appropriateness, the fit with local service delivery arrangements, the feasibility, okay, of implementing, are the billing mechanisms in place? What happens when people, you know, do health facilities have the capacity to be impaneled and then to offer reimbursement? Are they set up for that? Do they have information systems? And then you'd also look at fidelity. So in those out-of-pocket payments, was the smart card ever used, actually? You might want to ask. All right, so now in this, we're moving to the stakeholder analysis. We said we're going from this side, okay, the hardware stuff, okay, around health systems, not much of software in that paper, but we accept that this is important, and moving much more towards this side of thinking in the HPSR. All right, so you showed this for 1 nanosecond, Taurik, the definition. So I don't know if anyone had a chance to read it, I don't think. But I put it in tiny writing there because I wasn't going to read it out again. But it's a formal definition, which is in that paper, an approach, tool, or set of tools for generating knowledge about actors so as to understand their behaviors, intentions, interrelations, and interests. and for assessing the influences and resources they bring to bear on decision-making or implementation processes. Okay, that's the full definition. But essentially, that's what we're interested in: interest, position, and power. Okay, so that's at core what a stakeholder analysis is trying to get at. And what's important to understand, and what makes it methodologically quite difficult, is none of those phenomena are static. Obviously, it depends on the issue you're looking at, but it's things that change, that can change rapidly over time. And so being able to understand this as a snapshot, as not as an interpretation, as a moment in time. We spoke quite a bit earlier about thinking through carefully about the limits of the methodology and the limits to interpretation, and how to build in ways of ensuring that you feel more comfortable with your interpretations. Okay. All right, so we're interested, as we said, to analyze the why of policy outcomes, so it can be retrospective analysis, to assess the feasibility, viability of future policy directions, prospective design, and it can also be used to think about strategies. So it can be used to strategize. How, if you're a policy maker, how do I use this to better influence the politics around my policy? And so it can be used for not just design, but also thinking about action. So this was very well spelled out by the two presenters. You need to understand the context, identify stakeholders and their interests, define their position and power, and develop a strategy on the basis of that. Okay, so that's what a stakeholder analysis should do, especially a prospective one. All right, so now let's talk a little bit about power, okay, because that's quite a complicated thing to get one's head around. And it's, as I've repeatedly said, it's an invisible phenomenon, so how do we understand it? So there are lots of ways of describing power. There's lots of theory about power, okay? So I'm just giving you some thoughts and ideas here. But firstly, that power is not just where you sit at the top of a hierarchy, okay? It's not just those who have formal authority in the system. There's also sources of personal power, and the policy process may stir up new ways of new power relations. And all of this existing in a context that influences organizational, personal power and the policy process. So power is distributed, actually, in systems. It doesn't just reside in one place. So there are different forms that power can take. Okay, so there's the stuff where people are in authority, able to make decisions, or managers in the system. The people who can issue commands, tell you what papers to read, what you have to present, what time you come to class. Okay, that's power over. The ability of the powerful to affect the actions and thoughts of the powerless. That's power over. Okay. But that has limits, all right? Because there are other forms of power. There's the power to, okay, the capacity to act and in fact the capacity to resist. And that's referred to as agency. So there's a whole body of work in the field of policy called street level bureaucracy. Does that word, you've been exposed? Next.
Yeah, in the next
yeah.
bit. Did you do street level bureaucracy? No.
Okay, so it's the capacity of people at the front line to decide, okay? And remember we spoke about the fact that the health system is a peopled institution. There are thousands of transactions happening on a daily basis. People at the top of the system do not sit there in the room watching those interactions and controlling them. And there's a lot that happens at the coalface, particularly at levels of facilities, that fundamentally determines as the rules of the game. Okay, so they are micro-governance actors in a way. So, and the ability to cook the immunization figures, so to to please the district manager, so that to pretend they're reaching the targets, or to break the rules so that they can meet someone from another sector. Okay, it could be in the public interest. Doesn't always have to be negative and breaking the rules in a negative way. Right? So that is the power too, and the extent to which frontline providers and managers, middle managers, are able to extend that circle of agency around themselves, and often it's quite a personal phenomenon, will determine the extent to which they can exercise power. And so power is quite heavily invested in people across the system. There's also the power with, so the power of numbers, collectivities, the synergy of collective action, social mobilization, and alliance building. So individual actors that may be powerless, when they get together, they can be quite powerful. And then there's also the power within, which links to agency, a sense of self-dignity and self-awareness that enables agency. So what people in management or psychology, social psychologists might call the locus of control. Where do you feel that you control your own existence? Or do you feel your existence is entirely at the mercy of people around you? Right? That notion of locus of control. And the greater your own internal locus of control, the greater your agency in the system. So there are different forms of power. Okay. So this is, they referred to mapping power. Okay, so that was the force field analysis. So this is typically what a stakeholder analysis would come up with. And they showed you the one in the paper comparing Tanzania and South Africa. And essentially what you'd have is you map your actors, and again you'd have to think through their forms of power. Who are they? What is the power there? Okay, do they have? Even if it's potential power, maybe they're not exercising it, maybe they're not mobilized, but they have power. Trade unions, for example. So you rank them according to power, and then you put their position. So the interest part would be identifying all the relevant stakeholders involved, those with an interest in the issue, and then their power, you'd rank them here, and then you'd place them in a block as either proponents of the policy, neutral. If they're powerful and neutral, get them on your side if you need that. Okay, or if or they may strongly oppose, so you manage the resistance. Okay, you can't co-opt if people are resist, or you find ways of winning some of them over. And those not mobilized, if they're very powerful, you should get them on your side. So that's essentially what a force field analysis would do, quite simple. So you would put all your list your actors, and then you'd place them in these boxes. After a careful and qualitative analysis of where they sit, of course, in all of this. But as the paper says, you could actually get people around a table and do an initial one. And then you design strategy. Okay. So high support. So what do you do then with actors? These are the range of actions that your strategy could include. If you're a policy designer and implementer, you could involve people. Okay. You can seek to collaborate, you could defend, or you could simply monitor. And what you will do depends quite a lot on where they sit on the level of support: high support, oppose, high threat, low support. So the extent to which they represent a threat. So here something of their power is included. And then you develop strategies. Okay? So if it's high support, you must involve. Okay? If it's high threat, you need to defend. If it's low threat, just monitor. Don't waste your time involving. Low support and low threat. Don't waste your time involving and mobilize, because you're going to waste your resources. So that's essentially about how you think about strategy. Do you involve them? Do you collaborate? Do you defend? Do you monitor? And it would depend a bit on your stakeholders, where they sit here. And so you don't have one strategy for all stakeholders. You would approach it in different ways. Okay. And so the paper spoke about different kinds of strategies. So you can use power to undermine the actor, to defend. You can alter the balance of mobilized actors by mobilizing other players. You can alter the actor position on policy. You give them some incentives, information, or you change the way they think about it. So often the media plays a powerful role in shaping perception. So you have much more proactive communication strategies that set the agendas. So there are ways. That's really just reformulating what's written in the paper and what was presented earlier, and that strategy diagram I showed. So that's it. Stakeholder analysis, power, interests, and shaping those. And I've put these two in the Dropbox. Good. Any questions, comments, thoughts?